Thank you so much, Dr. Sung. It is one of my greatest honors to be here with you all today to present on a topic I care so deeply about, which is the future of gender-affirming voice care, particularly frontiers in research, clinical care, teaching, and advocacy. As you all might know, my name is Brian Nguyen. It's a little bit surreal to be here. 7 years ago, I started here as an intern as part of the residency training program, and so it's both surreal and really a great honor that I'm so grateful for to be presenting with you all today. I have no disclaimers. One of my primary objectives is to discuss how vocal structure and function communicate perceived gender, and how we can leverage that anatomic and physiologic understanding to understand the latest on the treatments for vocal gender affirmation, as well as push those particular frontiers here at Stanford for our transgender and gender nonconforming patients. But first, we should talk about this invisible force that rules us all, which is gender, and particularly in our society, the gender binary. What is a gender binary? It is the belief that sex is binary and directly determines gender. Sex is defined as the biological makeup of an individual, including their hormones, genitalia, chromosomes, transcription factors. Gender is a social understanding, a social construct, which describes what it means to be a man or woman in a specific culture, which changes across time and geography, as well as how a particular individual self-identifies as male or woman, female, both, neither. And it's important that we understand how identity, that mental concept, psychological, internalized concept of identity, how sexual or romantic attraction, sex, and expression all are really discrete, disparate variables or phenotypes that are unto themselves non-binary and have a wide range and diverse variety of expression and phenotypes. And all of us in this room have diverse meanings and understandings and sometimes even fluid conceptions and self-conceptions of identity, attraction, sex, and expression over time. What does it mean to be transgender? Transgender people have gender identities different from the gender they were thought to be at birth. For example, a transgender woman believes herself or themselves to be and identifies as a woman, which is distinct from the gender or sex they were assigned at birth, which was male, often male. And conversely, transgender men are and describe themselves and identify as male despite being assigned female at birth. There are also folks, including me, who identify as non-binary or who describe themselves as neither male nor female and kind of lacking a gender but more fundamentally human than really anything. And we are also considered gender nonconforming. Gender nonconformity exists outside of this traditional medical, social, political landscape of transgender people or transgender patients, and folks who violate the gender binary in any means, including, for example, female folks or female identified folks who pursue particular professions, or male folks who wear certain items or pieces of clothing or style their hair in particular ways, also violate the gender binary and are considered gender nonconforming, and are also, unfortunately, subject to sometimes severe consequences and stigma in our society as a result of the power of the gender binary. Per the National Center for Transgender Equality, I use male, female, man and women per their gender identity, not their biological sex or an understanding of sex as a biological construct. Importantly, everyone, including everyone in this room and everyone on Zoom, has a gender identity, whether they think about it or not, and whether they are transgender or not. We all have an internalized concept of who we are as a particular gender social understanding internally and how we express that externally to the outside world. What is gender dysphoria? It's a medical diagnosis, literally an ICD-10 code, that comes from the distress of the contrast between gender, that the gender that folks are thought of to be at birth, and the gender they know themselves to be. It's important to know that this particular emotional distress is primarily a social stigma-driven event. There are folks, particularly non-binary folks, especially now in today's society, who don't experience gender dysphoria despite being gender nonconforming. And it's really an ideology that's based in a social stigma. And this particular dysphoria can be relieved by expressing one's gender in a way that a person is comfortable with, including medical treatments, surgical treatments, legal identity proclamations, and social understandings as well in their community. On its own, being transgender is not considered a medical condition. There are folks who are transgender and gender nonconforming who are very healthy and describe themselves as healthy And so there isn't a particular understanding that they are sick unto themselves or deserving of health care simply for being transgender, although oftentimes because of the social stigma, they suffer from gender dysphoria. It's important to understand the alternative of gender dysphoria, which is gender euphoria, which has a broad variety of different dimensions, including a cognitive euphoria, which we all would love for ourselves and for our loved ones. This idea that we love ourselves, that we're lovable as our authentic selves. A social euphoria, where we are called by our correct name and our correct pronouns. And a body euphoria, where our body feels like our own and feels natural to us. Something that a lot of us take for granted, and something that transgender patients really are important to one of their goals in social and health goals. Gender transition is kind of often related to the alleviation of gender dysphoria, and as a medical, surgical, legal, social, internal, psychological transition that can happen, and looks very different from patient to patient. There's no prescribed way or format or formula or an algorithm that patients have to follow or should follow in order to transition to be their own gender. It's often a misunderstanding and an assumption by healthcare providers to assume that a successful gender transition looks like a particular way for patients, when it is entirely patient-driven and patient-centered. As we understand this, the gender binary and gender nonconformity, as well as the transgender definitions and patient population, we can use that understanding as well as something that we are so comfortable with, which is head and neck anatomy and function, to help these patients achieve their health and social goals. Fundamentally, we all know that our voices are who we are. Not only do they instantaneously communicate gender, they also communicate a wide variety of social attributes, including age, health, wealth, literacy, intelligence, sociability, trust. All of that information is communicated intimately within the quality and production of the voice. A lot of original literature has been used to describe, and something that some of us have known anecdotally, but fundamentally from a biological level, of how exogenous and endogenous hormones, particularly testosterone bioactives, influence the shape, contour, and size of the larynx, particularly the laryngeal contour, and the bulk and length of the vocal folds. As we know, testosterone can influence the muscle size in any muscle of the human body, particularly the thyroidnoid muscle in the vocal folds. And exposure to exogenous or endogenous testosterone bioactives, that muscle can increase in bulk, length, and mass, which I will show later influences fundamental frequency. These CT cross-sections can demonstrate how that can change for patients varied by exposure to various endogenous hormones. I like the study that was first authored by a colleague of ours in Sweden, who I had the pleasure of meeting at WPATH, which is the World Professional Association for Transgender Health in 2022, Ulrika Nygren, who used MRI to understand how women with congenital adrenal hyperplasia affected how their particular endocrinological condition affected their voices. So we can see in a really dose-dependent manner almost to their endogenous hormone production, how female controls and male controls and women with congenital adrenal hyperplasia had differential phenotypic effects to their mean fundamental frequency, their maximum fundamental frequency, the cross-section of the thyroidnoid muscles with graded exposure to testosterone bioactives, as well as their vocal fold length, which is kind of consistent with our understanding of how testosterone affects that muscle. What was really helpful for my fellowship to really understand vocal folds as kind of a string, and how that understanding from a physics perspective can really contribute to what we can do surgically to accomplish fundamental frequency goals, and how increasing the tension of the string can increase fundamental frequency, how increasing the length of the string can decrease the fundamental frequency, and how increased mass also has an inverse proportional effect on fundamental frequency as well. While this is our kind of understanding of how folks who are assigned male at birth and folks who are assigned female at birth have a particular range in their semitones on the piano, gender perception of the voice is so much more than fundamental frequency, and includes such critical factors as resonance, intonation, prosody, articulation, and all these factors are functional factors that are not influenced by surgery, but instead are behavioral treatments and behavioral factors that are influential to perception of gender in the voice. critically also is how our central nervous system plays a role in vocal production. In addition to complex auditory feedback, as well as really intricate understandings of how our emotions and histories and trauma affect our vocal production. I always tell all my patients that the voice and the larynx is an incredibly emotional organ, and there's a lot of evidence to show how those emotions in the limbic system and the way we perceive our voice, including shame, guilt, embarrassment, pride, euphoria, dysphoria, affect speech therapy and surgical outcomes. He's using what we understand from a CNS perspective, a functional perspective from the lips all the way down to the larynx through the pharynx, as well as this glottic level on a string theory basis. We can really affect change for our patients. So I was lucky in my Portland time experience to work with a vocal coach by the name of Anna, who herself is transgender, and was able to perform flexible laryngoscopy for her, doing particular exercises which helps influence and show what the larynx and pharynx do during certain vocal treatments. And I'm going to put my laptop next to the speaker here for sound. So Anna, what were you doing there?
I'm breathing in a way that shifts the voice box to a higher position, and I'm narrowing the pharynx, the throat, to reduce the size and space of the resonant chamber, which is going to create a more feminine vocal tract.
Yeah, and you can really see that here on endoscopy. Anna, do you want to do that one more time? Yeah, the way that she curled her arytenoids there and really compressed her pharynx, I completely agree from a surgical anatomy perspective that can really help reduce the diameter of the pharynx, turning a flute into a piccolo, which is really nice what Anna did there. And the next exercise she did was a masculinization exercise, which we were also able to capture endoscopically as well. So it's really beautiful the way that you can see the way that Anna very skillfully arranged the resonance in her voice. You can see compared to the feminizing resonant breathing techniques that she did, this way the pharynx is so much more open. She flipped her arytenoids outward, backwards. The back walls here and the side walls really open to help create a really much more masculine resonance. Yes, it's like the inside of a cathedral here. So yeah, the really powerful ways that, it kind of demonstrates the really powerful ways that a vocal coach or a speech language pathologist can really influence change, particularly with nuanced pharyngeal control in achieving particular outcomes. So knowing what we know about the larynx, we can help our patients achieve that vocal authenticity. And looking backwards, here at Stanford, actually, with my mentor, Sam Most, using Qualtrics, we were able to understand how exactly important it is for our gender to be accurately represented by our voice. We surveyed about 2,500 mostly cisgendered, straight, general adult American population survey respondents, and found that our cohort, using a variety of health economic exercises, were willing to risk a 15 to 20% risk of death in order to cure their vocal gender dysphoria. And in another health economic exercise, we're willing to give up 10 years of their remaining life in order to get vocal gender dysphoria treatment. Further, when I compared it to monocular blindness control, there was no statistically significant difference in the health utility of having one eye blind compared to the disease burden of having a voice that did not match one's gender. And interestingly, there was no difference between our survey respondents who identified as liberal or conservative. And these health utility estimates are likely underestimates, given that these survey respondents were not actually, the vast majority of them, 97%, were not actually transgender identified or gender nonconforming. They were primarily cis-identified folks. So focusing on transmasculine colleagues, what can we do for them, and what are the kind of standards of care currently of their vocal gender affirmation treatments? Dr. Jarmus was one of the first people in our literature to really describe the effect of androgen therapy on the female larynx. And Dr. Jarmus tells me this is one of his most excited and talked about case series or case reports that he's published. Still getting mail apparently to this day about this paper. But it really shows how on this case report, exposure to an exogenous testosterone really drops the fundamental frequency by the 4-month mark for this patient, who actually happened to be a jazz singer as well, and how that also decreased the vocal range for that patient as well. Dr. Nygren, as well, our colleague in Sweden, also looked at this from a longitudinal perspective in a patient population, in a case cohort, and found that the mean fundamental frequency actually levels out by the 12-month mark, and certain patient-reported outcome measures of the subjective vocal experience for these trans men also leveled out around the 12-month mark. So that's something that this paper is what I use to counsel patients about how testosterone affects change for these patients in terms of when to expect the testosterone to kick in terms of their effect on their voice, and how that effect is expected to stabilize or not over time. Aaron Ziegler was a speech-language pathologist that I worked with in Portland. He used to be faculty at OHSU. He published this really great meta-analytical review, finding that while the vast majority of patients who were trans men were happy with the effect of testosterone on their voice, almost 21% of men were still unhappy with the effect of testosterone on their voice, or either insufficient or with a lot of adverse effects. So important to know that testosterone itself is not an end-all be-all cure for transmasculine vocal gender dysphoria. And instead, we also have additional powerful adjunctive treatments, including speech-language pathology and voice therapy treatments, as well as a treatment that we will offer here, which is a type 3 thyroplasty to lower the vocal pitch in trans men. Anatomically, it involves these parasagittal cuts in the thyroid cartilage to depress the anterior commissure, to relax the resting length of the vocal fold, and as we know from that prior discussion of the string theory of vocal folds, which will then decrease the fundamental frequency, which is seen in their cohort here out of this Dutch group. What about for our transfeminine colleagues, our transfeminine patients? What can we do for them? It really goes back to this understanding of CNS control, the effect on the glottis, and the effect of the pharyngeal function on vocal production. I was lucky at the WPATH to work closely with a lot of really amazing colleagues, and here are the discussion and publication for the 8th edition of Standards of Care on vocal gender affirmation treatments from really amazing colleagues in Montreal. And speech therapy is really the primarily first main goal, although historically there have been some surgeries that have been offered for these patients, including psychothyroid approximation, which was published first by Ashiki here, involving placement of these permanent stitches to rock the thyroid cartilage forward compared to the cricoid, tensing the vocal folds to achieve that higher fundamental frequency. Also, there is very popular Wendler's glottoplasty, which involves an endoscopic web. And this really beautiful in silico study demonstrated that really the 40 to 50% mark is where you could place a stitch on the vocal folds. And there is a trade-off between vocal folds fixation, where the more vocal folds length that you fix, leading to a shorter vibratory length, a powerful decrease in sound pressure level occurs. And so I always caution my patients that a risk of this procedure is a decrease in vocal power and endurance and breath support, and that really this in silico study helped guide a lot of laryngologists to put the stitch at the 40-50% mark as a result. In this study here, they found a lot of how pitch ranging surgery can affect the vocal outcomes for transgender women, comparing Wendler's glottoplasty to cricothyroid approximation. And the key understanding here is that cricothyroid approximation drastically reduces vocal range and drastically reduces the ability to achieve certain lower minimum fundamental frequencies. So in general, I am trying to stay away from cricothyroid approximation in favor of other surgical alternatives, which have been proven in an evidence-based manner to be more effective and safe for our patients. Dr. Orloff, too, this was a paper actually I read as a medical student that made me really excited to come to Stanford. Dr. Orloff, in her many prior years before being having her incredible head and neck cancer endocrine surgery career, was actually a really prominent laryngologist who served an incredible community of patients that actually got to meet in a research project of hers, writing a textbook chapter. But she helped formulate this idea of laser-assisted voice adjustment in, I apologize for the outdated term, in transgender, gender nonconforming folks, actually co-authored with Dr. Darmos's brother, where CO2 laser is used as to form troughs to decrease the vibratory decrease the mass of the vocal folds, and therefore, according to that string theory, increase fundamental frequency. And here are her perioperative outcomes there. Dr. Hyung-Tae Kim is a major mentor of mine, who is one of the foremost vocal feminization surgeons in the world. He he does a surgery, which he describes in this paper here, about 5 times a week, with 20% of his patients approximately coming from South Korea, but the vast majority come from outside of Korea, including the vast majority from the United States. When I was there in Korea, patients from Russia, Kazakhstan, Brazil, Thailand, Germany, Russia, all saw him and saw his expertise, and he is one of the most sought after leaders in vocal feminization surgery in the world. And so in this paper, he really describes using first exposing the larynx in a Lindholm laryngoscope, placing it actually in the glottic inlet on the laryngeal aspect of the PDL, not in the vlecla as we often use, and using cold steel techniques to de-epithelialize the anterior half of the glottis, per that in silico paper theory of the ideal trade-off in vocal power and vocal feminization, and places 2 6-0 nylon stitches to imbricate the vocal folds together as seen here in a supraligamentous way, so preserving the ligament, preserving the tension of the vocal folds while decreasing the vibratory length. And a key difference between this procedure, which is he calls the vocal fold shortening retrodisplacement and anterior commissure, which we call the VFS RAC for short, is that part of his de-epithelialization includes the immediate anterior subglottis. So it's theorized to create this, and you see in the diagram on the far right, a funnel effect, which he describes as feminizing the resonance as well. I had the luxury and privilege and honor to visit him last summer after my fellowship for 6 weeks in Korea, living in the Gangnam district and learning from him so closely. I'm so grateful for his mentorship and had a really amazing time. This is one of my last dinners in Korea with his speech-language pathologist, and that far right with his speech-language pathologist and his patient care coordinator staff, whom I became really close to. Even though some of them didn't speak English, we bonded over their food recommendations in Seoul and their K-pop recommendations as well. And I really look fondly and really miss all of them in Korea so much. As Dr. Sung mentioned, the vast majority of my fellowship experience was in feminization laryngoplasty with Dr. James Thomas in Portland, Oregon. Dr. Thomas, alongside Dr. Young-Tae Kim, are one of the most sought after vocal feminization surgeons in the world. He does this procedure 3 to 10 times a month and has a waiting list that ranges from 6 months to 2 years. And like Dr. Kim, does zero marketing because patients seek them out all around the world, including the United States. So I was lucky to learn this particular technique, which Dr. Sung has already done here with Alden Smith here at Stanford, which involves basically an anterior partial vertical laryngectomy, resecting the anterior portion of the thyroid cartilage, which is the most aggressive way to remove the thyroid cartilage in a chondrolaryngoplasty manner to feminize the neck contour, to resect the anterior third to half of the true and false vocal folds, suture them together and tension them and suspend that neo-anterior commissure to a metal plate, closing the laryngeal construct, and shaving off the top half of the top portions of the thyroid notch and pexing this whole construct to the hyoid as part of a thyrohyoid elevation, theorized to feminize the larynx, theorized to feminize the resonance for these patients. So this is kind of a preoperative surgeon's view of the picture with this vertical anterior partial laryngectomy, opening the larynx in this manner here, creating a marking stitch with a Gore-Tex stitch, using Converse scissors to excise the anterior third to half of the true and false vocal folds, putting in these horizontal mattress sutures, which are then used to suspend the new anterior commissure along a metal plate that's also used to close the larynx. And this kind of demonstrates what we excise as a proof of concept of what this surgery actually entails. And this is an immediate post-op picture, which you can see is not only a vocal feminization surgery for pitch, but also for contour and aesthetics as well. We published here with Dr. Sung being our senior author, a study, a 20-year retrospective review on these patients showing that a lot of them had previous surgery, a lot of them had prior cosmetic chondrolaryngoplasty, and had a lot of vocal pathology before. And here are perioperative outcomes here demonstrating improvement in feminization of speaking lowest pitch with an also pitch range decrease. Increase in single item self-perception of self-rated item of third-party perception of vocal femininity. Complications are important to know. There is a risk of minor complication with almost 8% risk of infection. There was, within the 20-year history, 2 patients that had to have a tracheostomy as a result of postoperative infection. That was before he had routine post-op antibiotics, and then a 40% revision rate for KTP tune-ups for his patients. He uses blue light laser now. As a surrogate marker of durability of outcomes, we found that patients who had less than 1 year follow-up and patients who had more than 5 year follow-up, as you know, with patients traveling around the world, follow-up is really key, which is hard for these types of studies. There was no just statistically significant difference in outcomes between those two groups, kind of hinting at the durability of what feminization laryngoplasty can accomplish for these patients. We kind of dug in deeper into this idea that a lot of these patients had a voice complication coming in. And if we looked in the literature prior to 2021, we were seeing descriptions of complications from tracheal shave or chondral laryngoplasty as being as case reportable. And that kind of ran not congruent with what we saw in our patient population. And so we did another study, partnering with Dr. Thomas here at Stanford, focusing on how these complications occur and the prevalence of this and what they look like. So kind of a brief understanding of how these complications occur. It's important to know that about 1 centimeter from the inferior aspect of the thyroid cartilage, the vocal ligaments attach. And that attachment is like the strings attachment on the frets of a guitar. If that disruption occurs, the strings will slack and you will have extremely loose vocal folds, kind of like almost a new complete paralysis in terms of how that looks like stroboscopically. So it's important to respect that vocal ligament attachment when one is excising the thyroid notch as part of this aesthetic feminization of the neck. So one of the key things is Dr. Spiegel, who's a facial plastic surgeon who works primarily in facial feminization for patients in Boston and all around the world. In the operating room, he's described this technique, but here in the clinic, we can also verify placement or disruption of the vocal ligaments in patients who present with any kind of voice complaint after chondral laryngoplasty. Insert the scope in, take a good look at their glottis, pass a 25 gauge needle at the level of where you feel the end of the resection has occurred. And if that needle exits superior to the vocal folds, then it looks like their dysphonic complaint may not be related to anterior commissure subluxation. But if the needle goes into the vocal ligament or below the glottis, then it's fairly clear that the surgeon may have unintentionally resected too much thyroid cartilage and has therefore disrupted the vocal ligament, and like a broken guitar string, the vocal fold is now loose and has the unfortunate unintentional consequence of a transgender woman having a deeper, hoarser voice. In our cohort, we found of 94 patients who came in with chondral laryngoplasty, outside chondral laryngoplasty, 27 of them had a subjective vocal impairment after prior chondral laryngoplasty. And the key thing that I want to highlight here was almost 5 years have elapsed for the majority, for the median of these patients before they sought care, meaning these patients saw a lot of ear, nose, and throat doctors and laryngologists who were not able to diagnose complications from chondral laryngoplasty and have subsequently missed out on a lot of understanding of where their disease process came from or this particular surgical outcome. And those are the subjective and stroboscopic effects of chondral laryngoplasty complications. Using feminization laryngoplasty, which is primarily the main technique that we can think of now to address resuspending the anterior commissure, we're able to accomplish vocal feminization goals for these patients, which is great. Unfortunately, in our time landscape now, it's a really difficult time for the transgender, gender nonconforming community. In the past year alone, almost 500 pieces of anti-transgender legislation have been introduced. The dark red kind of really describes the worst active anti-transgender laws, including the ability for federal prosecutors or state level prosecutors to arrest parents who are seeking gender-affirming treatments for their children and pursue child abuse investigations for parents who are trying to affirm the identity of their transgender children. And that is only increasing in volume and fervor across the United States. We know that this is a very vulnerable population, and one of the key things is how we can ensure equality. And that's really where places like Stanford can really rise to the occasion. These particular treatments, these transgender people have been present in our human civilization for millennia, but often live in the shadows and have to hide in the shadows because of the power of the gender binary and the stigma associated with it. And so they often seek the help of private practice silos and private practice spheres to get the medical and surgical help that they need. And there's a growing movement, including places like Mount Sinai and Harvard, and now increasingly Stanford as well, where we can really be those academic centers of excellence for these patients. And I'm really excited to join an incredible group of clinicians and scientists as part of the LGBTQ plus team here at Stanford, which are over 20 clinicians and scientists involved in endocrinology, psychology, psychiatry, primary care, including family medicine, internal medicine, surgeons of all different specialties, including OB-GYN, plastic surgery, and urology, to really accomplish really incredible goals for these patients as a really well-coordinated, complex, powerful, motivated, heartfelt team for these patients, which is really incredible. So as part of Stanford's new Gender-Affirming Voice Center, we hope to offer a wide range of treatments for neck feminization, chondral laryngoplasty, as well as vocal feminization techniques, including voice therapy. I've been grateful to work with Anne and Dr. Beth Lorenzo for hiring a new particular gender-affirming SLP as part of our multidisciplinary program. We hope to offer feminization laryngoplasty with thyroid elevation, which is the only place outside of Portland, Oregon to offer this procedure, as well as the VFS RAC from Korea, which is also the only place in the United States or around the world that explicitly offers VFS RAC endoscopic technique, and the only place in the world, Stanford then being the only place in the world that will offer both of those procedures as a centralized place for patients to choose as part of their treatment armamentarium for their vocal feminization options, which is really exciting. We also hope to offer LAVA as well, the laser-assisted voice adjustment, as an adjunctive procedure for these patients as well. For our vocal masculinization options, voice therapy also will be a key component, as well as offering type 3 thyroplasty. So really Stanford being the only place in the world to offer these complex treatments that are often where transgender patients from all around the world can go to Stanford for a centralized place for their vocal gender affirmation care. And this can lead to really exciting opportunities in terms of education, with Stanford potentially being the location where future multidisciplinary, multi-technique expositions of surgical training can occur from an educational conference perspective as well as from a residency and fellowship perspective, and really exciting avenues for research as well. Lucky to collaborate with WPATH colleagues from around the world in advancing patient-reported outcome measures and looking at a variety of four-dimensional means of quality outcome determination, including patient-derived, patient-reported outcome measures, including new scales out of Sweden looking at self-efficacy and vocal self-esteem, as well as physician-derived elements, third-party derived elements, as well as artificial intelligence elements as well. This couldn't come at a better time, in the facing rise of incredible transphobia, legislated systematic transphobia and queerphobia in the United States. California's reaction in late 2022 became the first state in the United States to kind of be a shield state for our transgender youth and transgender adults, becoming the first state to legislate protections for any American citizen and any American child seeking gender-affirming treatment to come to California for their care, and also to protect these citizens, their parents, and these children from criminal investigations and child abuse investigations for seeking the care here in California, which is really incredible. That really makes Stanford an incredible beacon on the hill and an incredible opportunity to be that global nexus for clinical care, education, advocacy, and research for this really special population, which we care about so much. Thank you so much.
Wow, Brian, congratulations and welcome home.
Thank you so much, Dr. Shirago. That's very sweet. Any questions about anything? Yes, Dr. Chong. Yes.
I didn't know much about these different procedures, so thank you so much for showing them, and it was really great to actually visualize these surgeries. Is there like a certain patient characteristic that will make you choose one procedure over the other?
That's such a great question, Dr. Chong. For those on Zoom, Dr. Chong had asked what particular patient characteristics would make one choose one particular technique over another. I'm actually starting to book these patients that are coming out of the woodwork now, which is really exciting. And for me, I really take a look at a wide variety of factors, including the standard, holistic patient in terms of their past medical history and what looks best. When I look at feminization laryngoplasty, it is quite an aggressive procedure, and it is somewhat irreversible. For those patients, I really kind of reserve it for those who really are not great at, in terms of the stimulability and rapport for their voice therapy. They have really difficulty connecting with the particular exercises that even our best speech therapists can really kind of work with them. They have a lot of barriers to understanding with their acoustic perception of these exercises to perform these exercises effectively at home. And they really, the great thing about feminization laryngoplasty is it really cuts out what I call their dead voice or the lower register. So it's really effective at eliminating their access to the lower fundamental frequencies. There is a higher risk of infection, high risk of revision, and a somewhat long recovery process for some of them that requires sometimes adjunctive treatments. VFS-RIC is that Korean endoscopic technique is great for professional voice users. So our transgender, gender non-conforming folks who use their voice on a professional basis, whether they be, lawyers, politicians, doctors, teachers, singers, and really requires, as fundamental to its creative concept, to be really paired with pre and post voice therapy. So they really need to have good rapport with their voice therapist and demonstrate good stimulability in order to get the effective results. I also weigh their aesthetic goals as well. Feminization laryngoplasty is an aesthetic procedure as well as a functional procedure. VFS-RIC does nothing to their neck contour, although VFS-RIC has no incision. So those are the considerations that I have during my counseling session for these patients that I delineate specifically. Less airway, less infection risk, potentially less revision risk with VFS-RIC, but they still, for some of them, can access their dead voice accidentally too. But with appropriate voice therapy, that can really be treated. Really good question. Yes, Alden?
Thanks for this presentation. It was a great overview of a topic that I thought I knew a little bit about, but there's a lot that you presented that I thought was very enlightening. As access to transgender voice care becomes more widely available, I expect that patients will be seeking this care at a younger age. And so most of the patients that I've seen through my training have been in their earliest 20s, like early 20s perhaps. Are there any guidelines or thoughts regarding when vocal feminization or surgical vocal feminization should be pursued because of the rapid growth of larynx during male puberty or male sex puberty and et cetera? Do you have any thoughts on that?
That's a really brilliant question, Alden. It's also a very delicate question too.
Yeah.
In light of the current political landscape, gender-affirming treatments for children is really fraught. Unfortunately, I'm mentally preparing myself to receive, certain feedback, either online or, as an emerging potential public figure in this arena. And a conversation I hope to have continually with our LGBTQ plus care team, including Dr. Tandy A., who is, as you all know, one of our pediatric gender-affirming endocrinologists and leader of that program at LPCH. For me right now, I will probably only offer this customarily to patients over the age of 18 for primarily social, political, and legal purposes. Although I think maturation, our understanding of how the larynx matures over time, I think after exposure to these, based on the exogenous literature, the larynx after exposure to testosterone really comes into its own after a year of exposure. I'm the biggest fan of puberty blockade for these patients because that really preserves their options and minimizes their need for further health care, including vocal feminization. Although, as we know, that access is now increasingly restricted to and legislated against and politicized in various states. And I think it's something that it's a discussion that we will continue to have, increasingly so, as 1 in 5 children nowadays identify as gender nonconforming, which, as we know, is not a fad, but a really greater understanding and a reflection of the acceptance of the society by incredible parents and community leaders for these children. So, a pressing and important question that will evolve over time, and it will evolve for me as a clinician as well.
Brian, this is just a great time for you to be starting here doing this. I mean, as you've mentioned, this is such a fraught time, you know, when it's so interesting because 4 years ago, or, you know, when we started talking about this, in the otolaryngology world, this is really starting to take off, you know, and become a topic that was really being discussed a lot at national meetings, a lot of interest throughout the laryngology world. And then to have this sort of, you know, backlash, you know, just as things were looking so good, is, you know, certainly disheartening, and to some extent, but, you know, much the same as I think might be happening in the abortion realm. There are going to be sanctuary states and institutions that, you know, our mission is going to be, you know, part of our mission is going to be to preserve these avenues and possibilities for patients to come to us for this. So, you know, it's going to take, I fully believe it's going to take some bravery to do this, and I certainly applaud you and respect your dedication to this.
No, thank you so much, Dr. Sung, for that. Yeah, I think it's a function of visibility. You know, I think I had this conversation elsewhere too about how a lot of communities, when they're increasingly visible or made visible by the news or media, they've always existed. But whenever they're increasingly more visible, whether that be the Asian American community after the onset of COVID, when there's increased visibility, there can be an increased backlash. You know, and especially, you know, in the early 2000s with the increase of greater legal protection for same-sex and LGBT marriages and relationships, huge backlash that came out, and it was only with kind of one-on-one conversations that fractaled out into, you know, conversations on the legislative political stage that really effective change has happened, and now the vast majority of Americans really believe in the legal recognition and social recognition of queer relationships. And so I really do believe that the arc does bend, but it does take work. Yeah.
Brian, I'm concerned about your personal safety if this becomes a large thing. I'm not joking.
Yeah, I was going to ask you to be my bodyguard.
No, sir. No, sir. There's a lot of nuts out there, as you know.
Right.
There's a lot of nuts, and I worry about your safety.
Thank you. I'm not blasé about that at all. I think primarily by keeping a clear mind and a clear set of values, and keeping, sounds a little corny, but my head down and my heart open for these patients, then I think I will know the right way forward. But thank you. And thank you, I mean to say.
Bless you.
Any other questions? You have all my email. I think a lot of you also have my cell phone number. Please feel free to reach out anytime. Thank you again so much.